everyone. Welcome back to the I Rehab podcast brought to you by the Sports MAP Network. My name's Nick Kane. Today, as mentioned in our last episode, we are again with Seth O'Neill, but today breaking down the troublesome Achilles tendon that hasn't responded to your standard treatment and protocols. You're a little bit lost in where the athlete might be at. What are some tools and avenues I need to look at? So we'll be exploring that with Seth. I'd highly recommend listening to the last podcast episode with Seth to give a little bit of the background around some of the exercises and things, because there is some crossover. It was also mentioned that not to miss Seth's workshops in Melbourne and Sydney in February, and also the Solving Soft Tissue Conference early Feb in Melbourne with Seth and another range of fantastic speakers at that event. So shoot over the website and have a look. Also very excited to have Seth O'Neill's masterclass coming very soon. So giving some real visualization and details around all these things he's talking to. Hope you enjoyed the calf episode that was prior, and hope you enjoy this one. Thanks for tuning in, and we'll welcome in Seth. Seth O'Neill, welcome back to the How I Rehab podcast. And for those watching on YouTube, surprise, surprise, we're both wearing the same clothes. That's amazing to do that over the last fortnight. For those who missed the last episode, we chatted through the troublesome calf, soleus injury, and talked through I wrote some really interesting clinical gems around, I guess, how to look at things from a recurrent standpoint, because that's the sort of calf injury you see regularly now. And we know you're an expert, or you probably first really create the name around in the tendon space, Achilles tendon space mainly, and has been prominent on, Twitter over the years to, extend some of your research out there and make it really accessible. So I won't get you to reintroduce yourself again. For those that don't know you, just listen to the last episode. But today we are doing a similar thing to what we did with the calf, and going to try and throw at you some elements around Achilles tendon, because as I said last time, sometimes they're really easy to fix. They sort of pop up and you do a little bit of deload and reload and away you go. But sometimes they just don't get better and they don't respond like we want to. And they then come and see you. And I know another club, I work in the AFL, and another club asked me for your contact and got a player to see you, and we won't go into that in detail, but I guess the reference around those type of presentations that come to you from an Achilles standpoint. Let's start there. What do you see when they come to you and presenting to you, and we're talking 6-12-month history? What's your initial thoughts on the presentations?
Yeah, so often these players have had complex histories. Lots of interventions have been done and trialed normally in these cases. So they might have had things like high volume injections, steroid injections, hyaluronic acid injections, shockwave. They've had multiple variants of loading trialed, and may have made good progress and then relapsed. And to be honest, the clubs normally are not doing anything wrong. It's just when you step back and are looking at it as an external, one of the things that often stands out is just that the time frames that have been targeted, that the players were doing really well. They just got a little bit overloaded. And then because they overloaded and flared, often people go back to the drawing board and try and start again. And actually all it needed to do was just a tailored drop, and then just a gradual build back up again is often all that's necessary. The other side is then really around the structural change, that often the diagnosis that we've got has not been actually that useful and that good. We have some significant problems with imaging, where if you're using B mode, ultrasound, or an MRI, it will not always show the appropriate problem or identify the problem from a tendon perspective. So our preference is always to get a UTC scan done if able. So there's a few in Australia, there's obviously a few in the UK, and it gives us a lot more information about the severity of the structural change and spots changes that aren't always visible on the other modes. I had this last week in a consult I was doing for a football club last week. Exactly the same thing. They'd had imaging. Nobody's really talked about an Achilles problem. They had loads of treatment for these other foot and rear ankle conditions like osteogonums, posterior impingement. They'd had some nerve interventions done and other things, but actually the Achilles had significant changes on scanning, and really that had never been flagged on all the other imaging. So I think imaging can be really important here. and identifying what's going on. And then the other bit with a lot of these players is again around quantification of calf capacity, very similar to what we look at for a calf injury. So the isometric, the IKD tests, to really understand the sort of requirements of what the calf should be doing. Because if it's functioning well, it will offload and protect the Achilles. If it's not functioning well, the tendon takes the brunt of the force, and that's part of what causes this. But also it's a real barrier to recovery.
All right, lovely. So I guess the first thing you mentioned around a bit of a flare and a bit of deload and roll on. I'll start with more around the imaging stuff you talk to, because I guess we can get an MRI and the report might come back as moderate grade Achilles tendinopathy, with varying degrees of detail about what's in there and what we're seeing. And you're saying between that and ultrasound, it's not enough. Is that because you're more talking around the degree of change of pathology, or is there other like subsets of the diagnosis that may be there that we're not being able to tease out? And I'm probably referencing like a tear or a split or something along those nature as well.
Yes, the subsets. So longitudinal splits or very small sort of flap tears will be the real problem. And they're the group that certainly in my hands, if I try and load them up heavy, I make them worse. They're a group that arguably needs something else doing. So a short period of immobilization if they're an elite athlete, and possibly something to irritate and stick together that sort of torn area. So that's where we might consider a dextrose injection, prolotherapy, and actually use something sort of quite old school like that rather than some of the modern injections that will be utilized. They do really well with that. So they're the group that we often see, and I see far more of them in sports than I do in a general population.
So would you say, that's right, those ones that last a long time in a sports setting and they're just not responding, how would you tease that diagnosis out? Is that through UTC, or is that maybe just getting a better handle on the initial imaging, and MR and ultrasound can show us that if we get the right feedback?
Yeah, UTC is my go-to on it, and a lot of the leading foot and ankle surgeons over here that do all of the sports consults now will really want that done with all of their athletes that they're seeing as well. It just provides a lot more information than the other kit can, but some of it is the reporting and the radiologist that you're working with, and then considering whether this is a tear or not. Because the two look very similar on a scan in terms of having a sort of collagen tear versus having pathology that's tendinopathy and simple degradation. So also from a clinical perspective, for us on a day-to-day basis, we've got to think about our simple presentation. So for me, if the athlete was describing a pain that came on during an activity, there's a very strong indicator that could be a collagen tear. If he comes on the next day, they sort of come in and then reporting it, probably tendinopathy, and it's a sort of flare. So whether you call that a reactive tendon or not, but where it came on during an on-field session or a weight session, they got niggly, even if it's a gradual onset in that activity, that's when I would really consider potential for collagen tearing. And if it's not responding to normal rehab within 5 or 6 weeks, again, I would consider collagen tear being very possible in those instances, and imaging needs to then be done to examine them.
Okay, so some really good points around always feeding back to asking around the mechanism and not just going, oh, you got an Achilles soreness that's sore in the morning. It's A, B, and C. Go back from the. Let's ask that question again. Go back from there, and you talk to so stepping away from that subset of clinical diagnosis there around the tears and back to, I guess, a tendinopathy pathway that you see, and what UTC provides you in greater knowledge. What does it give you more detail around, and how do you use it? And I guess what inferences can we maybe take from that when maybe we don't have access to it?
Yeah, that's a tricky one, that last part of it. So really, we know structure is the biggest risk factor for developing problems. And this is why looking at structure is important. We know, despite what often the common message has been, that structure does correspond to pain and does correspond to functional outcomes. And that's data from Karen Silbernagel's research group that shows a good relationship between the two. And there's more data coming out on that as well in the next year or so. So structure is relevant and critical. We can see it change. In my hands, when we're looking at an elite sort of player who's worth multiple millions, we want to track structure, because if we're seeing functional performance benefits, returning to play, and we're getting better, but the structure is deteriorating at the same time, that's when we're a little bit more concerned about the potential risk of that return to play. So in order to make those decisions, we find it's very useful. Often where that advice has been ignored or not followed, that's where the athlete's gone back and tried to return to play and then had a significant relapse or even a sort of tear occur. And certainly in rehab, I've had patients who ruptured during rehabilitation. That's often been, well, it is predictable on the imaging, but it's because we've sort of made a decision of, well, we think they're going to cope with it, and it's just got to be accepted as a known risk. But they have then had a more catastrophic injury, shall we say. In terms of how we use that when you don't have access to UTC, that's a bigger challenge, because obviously we don't know what we're missing essentially, and we have to use some of the clinical guide that we've got. So if performance is improving but symptoms are worsening, we're then left in a bit more of a quandary of what we do, of whether we carry on or whether we pull the athlete and allow them to plateau and stabilize. Whereas if we can add imaging to that mix and we can see that the imaging is also improving, we've got a bit more confidence to sort of inform the athlete that, I know it's sore, but that's just a small cellular reaction, some chemicals excreted, your performance is better, your structure's better, this is going in the right direction. And actually, that's really critical to an athlete to understand that things are looking good, even though it might feel worse, because it's very easy to get het up and worried about the symptoms they've got, and the psychological impact of that on their ability to play, their ability to integrate socially within the club can be quite profound. And these athletes are the older athletes, the more senior athletes, who are often the captain of the club. They're really critical in the locker room and really critical out on field. And if we can get them back sooner or keep them on the right mental path, we're doing well. We know that a lot of these will take early retirement or be considering early retirement because of this psychological impact of the injury, especially if it's been a long-standing one and has persisted for over a year.
Yeah, okay, that makes a lot of sense, and we obviously know, that they can be really sore, but their imaging or pathology might not be too bad, so it's really hard to make those choices. But I think as you mentioned, there's some nice framework, a little bit around, I guess, symptom and the performance layering. So these athletes that are coming to see you, and now we've moved away from the subset of that population. They don't have, a split tear, their tendinopathy. You've UTC scanned them. They've tried different variances of loading. May have been doing some really heavy eccentrics and different things like that. How do you go about loading? And I know that you see some non-athletic population, some athletic, and I guess I want to tease out within this question around how do you do your loading? How do you do it with reference to pain, which you touched on last time, and dosage, and using that as our guide, because I've seen some of the stuff you do, and it's just a little bit differently to how some others might prescribe.
Yeah. So we've got several options here, and I guess the old adage of horses for courses is the right one to think about here. So we could go about it in two different ways. We could use low loads and do lots of it, or we can use high loads and do less of it, is essentially how we can split this. And this depends on the person we're talking about. So for a normal person from the village or town I live in, where they're not particularly athletic and active, then body weight and done regularly, multiple times a day, will probably be the way we'd go. Whereas if it's an athlete and we're looking at performance, we'll do 2 or 3 heavy sessions per week, much like we would do for our calf rehab. And around that, we would factor in some micro doses. So with our athletic population, we'd use, like I said, 2 heavy sessions, often done after their on-field session if they're back actually doing some performance. But on their rest days, we use micro doses. So that'll be 3 sessions over a day where they'll do heel raises until the point of feeling either the tendon gets a little bit niggly and stays niggly for a short period afterwards, or where they actually end up making the calf muscle feel like it's had a workout, but isn't obliterated. We're not trying to knacker the muscle and really fatigue it. We're just trying to give them a sensation of work and effort. And what that will look like in terms of actual rep count is, I don't like using reps. So I'm a real pain, particularly if you're dealing with people who are triathletes, because they like a number and like to have a rep count. Whereas I'm much more about the aftermath. So how their tendon feels later, or how the muscle feels for that duration. So the example being, we do some heel raises, and really I want them to get a sense of fatigue in their muscle. That's the ideal target. I don't really want to make the tendon get too sore. So if they got a 1 or 2 out of 10 pain during the activity, great. Equally, I'm not saying they shouldn't get any pain either, but I don't want it to be too bad, and I don't want it to last much more than half an hour after they've done that set. And that's their micro dose sort of work. The other side of it is, rather than reps, I often do a stop-start contraction. So we know that you get these problems with the muscle coordination where you get a visible tremor, normally visible during an eccentric phase. And that's the fast twitch motor fibers not coordinating fast enough during the contraction. So you get a juddering movement. And what we want to do is try and smooth that out. And these microdoses of doing a stop-start contraction as you go through the range of movement, a much stronger neural drive. It's much more about the brain patterning rather than muscle hypertrophy with that. And that's what we're initially trying to change in a lot of these people.
Okay, nice. And so you're working, I like the stop starts. So you're trying to address that tremor and get that control in the eccentric phase. You talk around pain and not lasting too long, and some of the guys who have done some other great work within the tendon space, back with Jill and Ebony, often talk around the morning pain the next day. And I guess the micro dosing, what you're referring to, doesn't necessarily means we need to wait until the next day to say, oh, how's that? Are you okay? It's sort of like, do it now. And if you're okay an hour or two later, hey, you're okay. And then you can dose again. Is that correct? But then how does the 24-hour response play a role, or does it play a role within some of your dosage?
Yeah, with the microdose, the real you shouldn't be sore the next day. So if they are, that's one thing. If it's the heavier work we've done and they are sore the next day, we'd always ask about it. We want to know about it. But whether we're talking about athletes or sedentary people now, it's not well tolerated if it's making them that sore the next day. And often people will talk about a 5 out of 10 being acceptable the next day. A 5 out of 10 is you're having to take medication to help with your pain. Above that, we're starting to get in the realms of I need some significant help and I've got a major limp. And so that level of discomfort is going to have a deficit on them that day, whether that's an athlete who then can't perform, or whether it's a mum or dad that can't then walk their kids to school because they're sore. So it has to be appropriately tailored in order to ensure adherence to the rehab regime. That's the problem. This pain that we get as the flare up the next day, it is likely to lead to non-adherence to the intervention, and that's going to leave us with a poor outcome. And that's why I'm not particularly enamored by high levels of discomfort the next day. But it is dependent on appropriateness. So if you've had a full game, say soccer, full 90 minutes game, and you then got 5 or 6 out of 10 pain the next day, it's appropriate. You've had a high vigorous load, probably covered 11 or 12 kilometers. You expect that, and it's in keeping. It's an appropriate aftermath. So it's about the appropriateness of that soreness. That's the key thing we've got to understand. Sometimes that's normal and okay, but if that's 5 minutes in the gym doing some weights and I'm that bad, that's not appropriate. That's too much.
Okay, nice. Yeah, I don't think I framed that question perfectly, but I think you've answered where I was like trying to go with things, to understand, I guess, both the short and that longer term aspect of pain monitoring, I guess, our load and dose response relationship. Okay, so I'm just trying to also just putting our hat on here that you're seeing someone who's had a longer term Achilles issue. So they may still be playing. So they might be that athlete that you've said there that they're playing 12Ks and sore the next day. which I'm sure happens, or they might be the player that's just, hey, they're out, they're too sore, the club's pulled them out and they're doing a loading period of time. In these type of athletes, like when that decision to get running, when can they start running, where we don't want to get that flare up, and how do we go about bringing that through? And then maybe we'll talk secondly to that player that is continuing to play but it's coming to see you and saying, hey, get me better because my Achilles is hurting, but you're playing soccer or football twice a week. So first point is like not running at the moment. When do I know I can start running? How do I go about that?
Yeah, so ideally, I'd want to keep them running. So I don't like to stop them actually running. So this depends on when they last run, how far did they manage to run, and how severe was that impact. And we look at that. Now, if they've been off their feet for 4 weeks, because that's how the clubs manage them, then we need to look at trying to get them back running sooner rather than later. And we'd use walking, our step count for the day, very similar to our calf work. We'd use brisk walking to see how they are with that. And then we transition into running as soon as we can. But again, it's often a linear, straight run that is non-acceleratory, non-deceleratory. So it's build up, get steady state, and then we keep going. And what we don't want to do, as we talked about before, is shuttle runs across the pitch or the court. We want to keep them going a reasonable distance, so a couple of pitches length maybe, or you get them on a treadmill and do it that way. Again, I'm not enamored by doing Alter-Gs and using the equivalent sort of treadmills for that, because the run mechanics can alter as we get them into an Alter-G. It changes some of the pelvic orientation and they actually often go faster. So our preference is normally on field, outdoors or overground running essentially, or on a treadmill. But ideally I want them to do it sooner rather than later with it, Nick.
Okay, yeah, love that. And the other athlete, so I'm coming to see you, Seth. My Achilles has been annoying me, but I'm playing. I'm playing every game, and I know in the Premier League they might play twice a week sometimes. But let's say, for argument's sake, training's really limited, paying the days after, it's affecting his daily life, trying to get the strength loading in. What do we do with that athlete? Is it around a balancing load? What's your advice in situations like that?
Yeah, these are the most common consult we have because the athletes sort of sore, but we're in season. They're a key player for their squad. So there's often not a good rationale for pulling them because they are critical for how they might do. Particularly this occurs during the back end of the season as we're hitting the sort of time where you're getting to cup finals or the difference between getting demoted or promoted. It's hard. There is no right or wrong. The ideal situation is we want to try and control a little bit of their time on field if we can in the game. These players are often very experienced and can read the game well and can reduce their distance covered by just positioning well. And they're often a midfield players, typically what we see, but it can be any other position as well. So they might self-manage it well, but we need to make them aware of then how we adjust training. And that's a discussion then with the coaching staff, the medical teams, and the player in order to try and control the training load and the training intensity. So we're not then overburdening them coming into the game as well. But often what they'll do is they'll have a full day off the next day. And actually our preference will be to use some very light load, maybe the microdosing we talked about on those days, in order to get some analgesic response for the tendon. Tends to warm up and feel better if they do that, and try and build that way. If they're terribly sore and can't tolerate high loads, we might use blood flow restriction in order to get a metabolic demand on those off days or on some of their training days as well, to try and control. And we might use things like inserts in the shoe to just put them into slight plantar flexion. So you're actually just reducing the tendon stress on their rest days or their other training days in order to give them the capacity to cope with the games, and maybe even have those in their boots for the actual games as well. But that's something that a lot of players don't tolerate because it alters their foot position in their shoe and they don't feel they can control the ball as well if it's soccer, football based. Different in sort of rugby and Aussie rules.
Okay, and so I'd gather there, we talked to, I guess, which a lot in the tendon space, the eccentric component, the heavy loading strength. I guess in this type of situation, you're not doing that, and I think you're not doing that much, I'd gather, and I think that might be a really important point for those that manage these cases out there. Or if you do it, how do you cycle it in?
Yeah. So we try and get 2 sessions still a week, but it's hard to structure around their training days. It definitely needs to be after an on-field day. So if they're doing, let's say they've done a game on Saturday, they typically have a relative rest day on the Sunday, back in the squad Monday, Tuesday with a game on Wednesday. What we then try and do is that the Monday session, they do an on-field session. They come in the gym and then do a short, sharp calf hit. So they factor it into their normal legs weight day, but it needs to just be short. And that's, again, a typical thing. We'll see 20, 30 minutes done on the calf, sort of 10 exercises with multiple sets on each bit of equipment. It just obliterates them. We need a short, sharp stimulus. So it's just doing bog standard exercises, basics, fundamentals, done really well in order to get that capacity built up. And it just needs to be quality. It's not quantity with these guys, it's quality of it. So heavy exercise done at those time points, but with a full understanding of what the consequence is afterwards. Does it fatigue them? Does it make them sore? And making sure we adjust it to tailor for that.
Cool. So it's still eccentric, or you still want to be able to have that eccentric bias like we spoke about in the calf, where it might be a 2 up, 1 down component still, but just not overcooking them and feeling okay the next day.
Yeah, heavy ISOs as well,
Yep.
But short duration with these. So we're not into doing long ISO holds, because what that's going to do is actually cause elongation of the tissue, and that's making the tendon more compliant, at least for the short term after you've done the exercise. And we've seen some significant negative effects with certainly Achilles ruptures with elongated tendons as a consequence of these heavy ISO long holds. So we want a short ISO heavy hold. So 2 times, 2.5, maybe 3 times body weight in a leg press machine, 3 to 5 seconds in positions of stress. So probably moving towards those dorsiflex positions, but not locking out into full dorsiflexion, or little short pumps in those positions to really get big stress through the tendon to stimulate actual change in the tissue. Because we can still get change in season. It's just harder to not overload the player and then have a performance deficit on them. And again, in an ideal world, if the club have a decent setup, we do an isometric test the day before the game in order to just check where their calf recovery is. So we can then see, or we embed it weekly, so we're not then seeing a drop off in their strength. And that could be done standard time after a game. We've done testing on squads pre-game and post-game with squads. We've had no negative deficits with that during the game or risk of injury, because it's a quick test. So after a game, you could build it in, but that needs medical team and player buy-in to understand the relevance of these tests and why we're then embedding it in. But if you do it after a game, there's no risk of injuring him during the game. So that then often gels better with a lot of people psychologically. So that's one way we can embed it, and we can measure weekly then.
Okay. Cool. Yeah, that's interesting that I won't go into detail of that, but the monitoring aspect of the seated calf testing, and, Mike Lancaster talked to it as well, in his masterclass on calf Achilles injuries in rugby, that they do it as a precursor to training and have not found, it to be a concern when it comes to maybe calf injuries, which is a bit of the clinician's fear, I'm sure, around, hey, do this maximal test and then you go and do your calf. It's like, it's that's fault, or there'll be an association to that if you happen to get that. So you guys have found no real negative effect.
No, and the key really is that Mike's done it for a long period of time. We've worked with Mike on it as well, and it's getting squad acceptance. It's a bit like doing the Nordic sort of hamstrings in the past, that until your squad's used to it and everybody understands that this is not damaging, the initial sort of things with the Nordics might induce some DOMs, but it's perfectly fine once you're used to it. It's the same for this test. I mean, it doesn't induce DOMs, doesn't induce any fatigue. And as soon as we've had some exposure to it and the players have done it a few times and everybody's comfortable, it is very easy and simple to build in then. So yeah, I would personally, if I was able to design a squad's rehab program fully and not have anybody else sort of really put a stress on it, it would be the day before a game. We'd do your full sort of set of hams, groin squeeze, and you'd do a calf test, and that would inform you about recovery. Add a jump in if you want, but none of those are really fatiguing if they're iso holds or even an eccentric. And then that gives us a good way of understanding where the players are at.
I like it. Couple more questions on around this case that we'd see, but you mentioned isometrics, and it was going to be one I'd ask. But and around this athlete that's playing still wants to be better, you've mentioned we're still able to get some good loading in, maybe less once or twice a week you mentioned, and then some micro dosing. Isometrics, I gather, for analgesia and doing that as a precursor to training and to warm up, so to speak, and feel good. Where does that fit? Doesn't it fit in your practice in what we're seeing here?
Yeah, easy answer is it doesn't fit in the practice, generally speaking. The evidence from multiple groups that have measured and assessed the response to isometrics for immediate analgesia has shown it doesn't seem to sort of actually give us the benefits that we had initially anticipated. Certainly in my hands, it can make some people worse. When we do it at the sort of long holds for 75% MVCs, and that's what other people have found. So basically, it's a very individualized response. If with an athlete you're working with, you find it gives some benefit and makes them feel better and makes them feel prepared, absolutely fine. Go with it. Just be aware of, there's a lot about how we sell it with how it comes off. So if you tell a person it's going to make them feel better, generally speaking, with anything we do, it will make them feel better. So we can use that placebo response with a lot of the interventions we do to do it. But most people get a simple warm-up response. So for me, I prefer to do something that will give PAP. So I'd use some excitatory stimulus like hop-in, bound-in, short plyos, pogos or something to do that benefit. I might use some small amount of heel raisers, again, just to get them fired up and working better. And often as part of our preliminary work with these athletes, we test that to see what happens with a battery of different sorts of warm-ups to see which one gives them the best response.
Yeah, nice. So really individualizing into your athlete. And that's some great clinical or practical application there. Final one on around that athlete with the loading. You said it mentioned, they might minimize their game time a little bit if possible, where they can. And the training aspect of on-feet training, I guess. One thing I've sort of found, how do you go about advising around that, I guess? Do you say, well, here's your 3 sessions. You mentioned the weeks, so that Monday, Tuesday, Wednesday, and then let's say they're playing Thursday. You're saying they're on feet every day, so just minimize how much you're doing on every day? Or do you say, just go hard on Tuesday and have the other 2 days off, and probably looking at optimal recovery and what works? What's best in that sense when they need to be on feet at least at some point? How do you go about it?
Yeah, so we have the ideal world of what we want in our head and maybe what the medical team want, and then we have also what happens with the coach and where a training session goes awry and is planned for an hour and a half or 2 hours, then ends up being 4 hours, and the athlete runs a huge amount more than was the initial plan. So that's part of the problem we have, I think, in sports is training will change on a day and often on a whim. So it's hard to sometimes really build that sort of plan in. My preference would be to have them run regularly, so their on-field sessions are regular without doing like a big blowout one, because ultimately what we'll find when we're looking at tendons is that the strain rate, so fast runs, high intensity runs, are the problem. We can build a cumulative time on feet quite well. So if that was a steady state run, we could get people running 10 miles, or for footballers, get them up to sort of 12K, absolutely fine. The problem we've got is where that's done at high intensity, high speed running, high change of direction, lots of jumping and landing. That's the bigger challenge. And that's where we want to ideally spread that over the week. So we don't have a day that's all on sort of accelerating into the box and trying to sort of do a short pass or a shot or something. It needs to have been spread out. Often this is where the clubs will use short games, small games. So it's a condensed pitch that makes it very fast and very intense, quick changes of direction. And that's the bigger challenge. So we want to really control that and maybe reduce the athlete's effort if they've got to do those. So instead of 100%, they're going at it 80% or 70% of their max. So everyone understands why they're playing like that. So they're still selected, but it's done to nurse them in.
Awesome. Okay. Mate, I've one last question, and we won't need to go fully into detail because we'll bring this to a close, but I know you're talking around this in your workshops out in Melbourne and Sydney, which we touched on at the start, but I guess maybe challenging some thoughts. You mentioned the UTC and how you're utilising that around pathology and the changes in pathology. Are you seeing the ability to improve the pathological tissue and get restoration or return of that? I guess I'm talking to the donut theory here, or is it more that we just need to stick with getting the strength to improve the healthy tissue there, and what we've lost, we've lost? That question makes sense, but I think it's a leading question.
Yeah, no, absolutely. We can improve tendon tissue. It categorically improves. There's loads of evidence around out there. Published work from Karen Silvernagle Group, Henmeyer's work, and a whole variety of others, Kongsgaard, that have shown this. So tendon does improve, and it needs to improve in elite athletes. Less important for our sedentary population, but for elites, absolutely. The biggest problem we have where we amalgamate the two, dodgy structure and neuromuscular weakness, let's call it, you get those two together, then we've got time loss. If we've got weakness but good structure, we'll cope, obviously. And if we've got dodgy structure but a nice strong muscle, for want of a better term, that's where we have a performance deficit. And they're the biggest group we have where you've got in-season problems. So really important to change structure. And our interventions need to target neuromuscular capacity and the structure at the same time. And that the interventions aren't always the same thing for both of those, but may have lots of overlap.
Beautiful, mate. All right. Well, obviously, again, as per the last one, I think some really good practical takeaways that we can use. And there's so much more we could probably unpack there and move. And hence the reason we are saying, hey, come to Australia, because I think there's so much interest in both of these areas. And, we had Brady Green run his calf course recently, who I know you've worked with a bit in the past, and there's some real crossover in the work there. So I guess, we're seeing lots of calf strains, and the Achilles tendon management is always evolving. So looking forward to having you out in Melbourne and Sydney and for our conference, mate. And thanks again for joining us on the second How I Rehab podcast together. And mate, we'll chat to you soon.
Cool. Thanks very much, Nick. Really looking forward to making it over to Australia. It'll be my first trip. So treat me nicely when I'm there. Hopefully get to see a little bit of it and maybe get in the water for a bit of a surf as well. But I'll try and avoid the sharks. So we'll see how it goes.
Mate, you should be all right in Sydney, Melbourne for sharks. I think we'll get you a surf and get you to a nice beach in Sydney, and just do your best in Melbourne.
We'll see what happens, man.
Thanks, mate.
Cheers, dude.